Good morning, dear students. So today is the turn for pediatrics, and from today onwards, we are talking about renal disorders or diseases of renal system. So as always, the first topic will be a bit of clinical type, means how to approach to a child with hematuria. Okay, so this will be a good insight to the system, renal system, what type of disorders are there, how they manifest in the clinical practice, and how we proceed further. Now, first of all, you should know what is the meaning of hematuria. See this, hematuria can be of two types: gross hematuria and microscopic hematuria. Gross hematuria means it is a frank red blood which is seen with the naked eye. Means the patient complained that, my child, the patient party of course is complaining that my child is passing red colored urine. This is known as gross hematuria. Okay, whereas the microscopic hematuria means the urine color may be clear, but under the microscopic examination RBCs are seen. So what is the definition? More than 5 RBC per high power field in a freshly void centrifuge urine. These are the criteria for microscopic hematuria per high power field. Okay, more than 5 RBC. The urine should be freshly voided and it should be centrifuged. Now, not all red colored urine, okay, is caused by hematuria. You have to understand that. Many of the time patient comes to the hospital saying that I am passing red colored urine or my child is passing red colored urine, but all of those cases are not of hematuria. So what are the other differential diagnoses of red colored urine? See here, the most important one is hematuria, of course, passage of RBC in the urine. Okay, hemoglobinuria. What is the meaning of hemoglobinuria?
Passage of the hemoglobin
Passage of
in the
hemoglobin in
urine,
urine.
excessive
Hemoglobin in urine.
hemoglobinuria.
Exactly. Very good. Passage of free hemoglobin in the urine. And you all know hemoglobin is present inside the RBC. So RBC should be ruptured first. Then only hemoglobin can come out. So hemoglobinuria is a very important finding of hemolytic anemia. Acute hemolytic anemia leads to hemoglobinuria. Now, can you tell some of the causes of acute hemolytic anemia? Yes. What are those?
So some drugs,
Okay, some of the drug reaction. Yes.
Drugs, malaria.
mal-
Malaria. Yes. Good.
Sickle cell anemia.
Sickle cell anemia.
Okay. Now, one of the important point I like to highlight here, there are two types of hemolysis which are going on. One type of hemolysis is mainly occurring inside the spleen. Another type of hemolysis occurring mainly inside the blood vessel. Okay, so we also call that intravascular hemolysis. That intravascular hemolysis mainly leads to hemoglobinuria. In other type also a bit of hemoglobinuria may occur, but it mainly occur in intravascular type of hemolysis. Okay, so the common causes can be, remember, mismatch blood transfusion. Mismatch, for example, the patient is having blood group A, okay, and the doctor mistakenly gave blood group B in the patient. Now that can lead to fatal, transfusion reaction. A lot of hemoglobin will be released and that can lead to hemoglobinuria. G6PD deficiency is another one. Autoimmune hemolytic anemia is another one. Okay, and drug reaction, if we give certain drugs, and they can also lead to hemoglobinuria sometimes. Okay, sickle cell anemia, thalassemia, and those especially, they are a bit of chronic type of hemolytic anemia. The chances of hemoglobinuria is not that high, though it can occur, but not very important one. Myoglobinuria. Now, another similar type of condition, myoglobin, okay, is a compound just like hemoglobin, which is present inside the muscle. The function is same. It also carries oxygen inside the muscle. When muscles are damaged, especially the skeletal muscle, then myoglobin is released in the blood. And similarly, this myoglobin may appear in the urine. So myoglobinuria. Remember, some crushing type of injury, crushing injury like road traffic accident or motor vehicle accident, okay, then stampede injury from the earthquake or earthquake victim, they will have myoglobinuria. Even after a very prolonged episodes of tonic-clonic seizure or generalized tonic-clonic seizure or grand mal seizure, they can have myoglobinuria. Heat stroke can have myoglobinuria. So there are different types of causes. Now, one very important point I like to highlight here, both hemoglobinuria and myoglobinuria can result in renal failure or kidney failure because these are the pigment which can block the renal tubules. And when renal tubules are blocked, remember, it can suffer from acute tubular necrosis. This is a nephrotoxic type of acute renal failure. Okay, so the person can have renal shutdown in hemoglobinuria and myoglobinuria, and this can lead to a death of the patient also sometimes. Apart from this, some food dyes like eating beetroot or blackberries can also have red colored urine. So we need to take a good history here. Sometimes a patient is taking some medicine or drugs like rifampicin or phenazopyridine. This phenazopyridine is a type of urinary analgesics. Sometimes it can be given in UTI when the patient is having pain during urination. Okay, just to relieve the urination pain, urinary analgesics are prescribed. Both of them can convert urine into red colored urine. Rifampicin, okay, is anti-tubercular drug. We all know that. Very, very important anti-tubercular drug. And after taking it, all the secretions will turn orangish red. Okay, it is orangish to red. So I need to explain this point to the patient party, otherwise they'll be scared. The sweats or sweating can also be red. Urine will be red. Okay, so this is done by rifampicin. Another interesting type of conditions are porphyria and alkaptonuria. See this, porphyria and alkaptonuria. Now, what is porphyria? Let's talk a little bit about it. Yes, please.
Accumulation of porphyrin in the body.
Exactly. Accumulation of porphyrin in the body, and one of the example of porphyrin is heme compound. Heme. Okay, so you can say porphyrins are accumulated if there is some disorder in the heme metabolism. Now, there are different types of porphyria, acute porphyria and the chronic porphyria. Acute porphyria mainly affects central nervous system and the skin, and chronic porphyrias mainly affect the skin component or skin part. Okay, now why this porphyria is discussed here? In acute intermittent porphyria and other types of porphyria, if we collect the urine and expose that urine to the sunlight, okay, the urine may convert into deep reddish in color. Okay, so we may get confused. Maybe this is the cause of red colored urine. Whereas alkaptonuria is another interesting condition. Okay, this is a disorder of homogentisic acid. This is the metabolites of some amino acids. So let me write the name, homogentisic acid. This homogentisic acid is accumulated in the body, okay, in case of alkaptonuria, and it is getting excreted in the urine. So when we collect this urine and expose the urine to sunlight again, it may be converted into dark red in color. So this is known as alkaptonuria. Now this alkaptonuria is a a bit of a interesting situation. This alkaptone, okay, alkaptone is oxidized compound of homogentisic acid. So it is not another compound at all. You can simply remember homogentisic acid is the main problem here. So homogentisic acid will be oxidized into alkaptone, and when that alkaptone is coming out in the urine, we call that alkaptonuria. That's it. Now sometimes this homogentisic acid is collected inside the cartilage, okay, in the cartilage, and it can damage or destroy the cartilage. That condition is known as ochronosis. Ochronosis. Okay, sometimes this ochronosis can lead to even a degenerative disease of the joint, and that is known as osteoarthritis. Osteoarthritis. So I'm giving a little bit more information so that from the next time when you hear this term alkaptonuria, you are not confused. Now, to summarize the things what we discussed till now, all red colored urine are not caused by hematuria. Yes, hematuria is the most important cause, but not every time. So you need to take the good history there. Let's move on. Now, can you see this picture? What can you see here? All of you, focus there, please. Now see this. These two, okay, the first and the second, a clear-cut case of red colored urine. This is red urine. There's no doubt about it. The third, probably after a few days, this red colored urine got cleared. So this is almost normal now. So this is how red colored urine looks like. And any patient who is passing this type of red colored urine, they are very scared. They definitely seek a doctor's help. And a child, if the child is passing this red colored urine, parents are very scared. They will definitely seek the doctor's attention. Now, another part of this lecture is what are the causes of hematuria? Now, let's talk one by one. First of them is a glomerular disease. Okay, you all know glomeruli. Glomeruli are the special sort of capillaries which are present inside the Bowman's capsule. So if these glomerulus are inflamed, we call that glomerulonephritis. There are so many immunological conditions, so many infectious disease, so many connective tissue disorder that can cause glomerulonephritis. Now, few of the examples are post-streptococcal glomerulonephritis, PSGN. Now, which streptococci is responsible here? Which is that streptococci? Yes.
Sir, group A beta hemolytic streptococci, Streptococcus pyogenes.
Nephritogen strain.
Exactly. Very good. Group A, beta hemolytic streptococci, the nephritogenetic strain. Absolutely. We'll talk about this in today's class, okay, later on. Focal segmental glomerulosclerosis, FSGS, membranoproliferative glomerulonephritis, mesangial glomerulonephritis, and minimal change disease, MCD. All of them, okay, are the glomerular condition which can result in hematuria. The chances of hematuria is very less in minimal change disease, but few of the patients may present. Another is IgA nephropathy, deposition of IgA antibody on the glomeruli and damaging that, So this is also known as Burzer's disease, IgA nephropathy. It can also lead to hematuria. Second, important types of causes are urolithiasis, also known as, kidney stones or urinary tract stone, you can say. Urolithiasis, renal stone or kidney stone, ureteric stone, and urinary bladder stone. All of them can lead to hematuria, all of them. Very, very important clinical feature. Urinary tract infection or hemorrhagic cystitis are important cause of hematuria. Now, any infection, in the urinary tract can result in RBC, appearance of RBC in the urine. And there is one condition known as hemorrhagic cystitis, which is mainly caused by adenovirus. Adenovirus. So let me write it here. Okay, adenovirus. And another cause of hemorrhagic cystitis is one of the medicine. It is a very powerful immunosuppressive drug. Okay, and the name is cyclophosphamide. Cyclophosphamide. This is the side effect of cyclophosphamide, hemorrhagic cystitis. Very important MCQ question. Okay, please remember. And adenovirus is a type of DNA virus which can lead to infection there. This is called hemorrhagic cystitis. A lot of RBC appears in the urine. Cystitis is inflammation of the urinary bladder. Some of the tumors may lead to hematuria, like Wilms tumor, okay, Wilms tumor, and some secondaries in the kidney. Now, Wilms tumor is very common in children, and secondaries can also occur. Means a malignancy from somewhere else can reach the kidney there. Okay, trauma, important cause. Okay, interstitial nephritis, which is a part of hypersensitivity reaction, any drug reaction, any other types of allergic manifestation. Interstitial nephritis can occur. It can result in hematuria. Renal vein thrombosis can result in hematuria. It is very common feature of nephrotic syndrome, renal vein thrombosis, and that can also lead to hematuria. Let's move on. Now, some other systemic disease or condition like, see here, connective tissue disorder or vasculitis like SLE, HSP, and PAN. Okay. Everybody know the full form here. SLE, systemic lupus erythematosus. What is HSP? What is the full form?
Henoch-Schönlein purpura.
Good. Excellent. Henoch-Schönlein purpura. Okay, HSP. I have spoken about this so many times in the previous lecture. So let me ask you this question now. What are the 4 components of HSP? Can you list them? Yes.
Arthralgia, abdominal pain, hematuria, palpable purpura.
Excellent. Very good. He has spoken it quite nicely. I'm sure other students can also, answer that. Now, this is HSP. Okay, let me quickly do that. We have a lot of time. Don't worry about time here. The understanding is important point. HSP has got 4 components for the diagnosis. Okay, those are, the first is always rashes. Rashes are present in 100% of the time, and these are the palpable rashes. These are big palpable type of rashes which are present mainly in the buttock area and in the lower limb. The second, okay, kidney involvement. That's why we are talking it here. Kidney involvement, and by involving the kidney, it can cause hematuria and proteinuria. Hematuria and proteinuria. Sometimes it can lead to renal failure as well. Now, number 3 is GI tract involvement. Okay, GI tract involvement. Now, by involving the GI tract, it can lead to appearance of blood in the stool, and very rarely it can also lead to intussusception. Intussusception, we have studied that in surgery. Telescoping of the proximal segment into the distal one is intussusception. Now, that's a very interesting mechanism there. By causing these, rashes or vasculitic reaction inside the mucosa of the bowel, that can act as a precipitating factor, for the, start of intussusception. Okay, and the 4th one, see there, the 4th one, okay, is arthritis. or arthralgia, arthritis, okay, or arthralgia, whatever you want to say. The difference between arthritis and arthralgia is arthritis is an inflammatory reaction inside the joint. Arthralgia is simple pain. There is no inflammatory reaction there. These four are the features of HSP. Never forget. By these four, components, you can diagnose HSP directly. This is a sort of clinical diagnosis. Now, what is PAN?
Polyarteritis nodosa.
Exactly. Polyarteritis nodosa. Very good. Polyarteritis nodosa. It's a type of vasculitic disorder again. Okay. So any type of vasculitic disorder, kidney is one of the main organ which is affected. Hemolytic uremic syndrome is another condition. We call it HUS in the short form, and this has three components together. So what are those three components of HUS? Anybody? Now those are hemolytic anemia, isn't it? Hemolytic anemia is one. Uremia means kidney failure. So two components are already given here. The third one is thrombocytopenia. So this is called HUS. Hemolytic anemia, uremia or renal failure, and thrombocytopenia. This is known as hemolytic uremic syndrome. It is mainly caused by infection in the GI tract, mainly caused by Shigella. Okay, this is known as shigellosis, which is caused by Shigella dysentery bacteria. And another bacteria which can lead to hemolytic uremic syndrome is a type of E. coli. Now, can you tell me which type of E. coli is that?
E.
Anyone?
coli O157.
E. coli
coli
017H7.
017
Excellent. Many of the students know that. Very good. So this is called enterohemorrhagic E. coli, EHEC O157H7. This O, okay, is a somatic antigen, and that H is a flagellar antigen of E. coli. And that's how that particular strain name has been given, O157H7. Never forget this. These two are the important causes of hemolytic uremic syndrome. And this hemolysis, which is seen here, is known as microangiopathic hemolytic anemia. Microangiopathic hemolytic anemia. In hematology, you have studied that already. Now, let's move on. Some other hematological conditions can also result in hematuria, like ITP. Here, ITP, idiopathic thrombocytopenic purpura, or immune thrombocytopenic purpura, whatever you want to say. This is a disorder of the platelet where platelet count is very low. And of course, when platelet count is low, there can be bleeding from any site of our body. So it can occur even in the urinary tract. Bleeding disorders, other type of bleeding disorders apart from ITP, okay, any other type can result in hematuria. Sickle cell anemia and aplastic anemia both can result in hematuria, but the mechanism is different. Sickle cell anemia can lead to hematuria by causing papillary necrosis in the kidney. Remember, renal papilla are the important structure inside the kidney. Those renal papilla are necrosed as a result of thrombus formation, because that is the main problem in sickle cell anemia. Those RBCs, they are sticking together. They are sickle-shaped RBC. Especially if the person is having infection or dehydration or hypoxia, then those RBC will be converted into sickle cell RBC, and then they clump with each other and form a small mass inside the blood vessel, which can lead to ischemia, and that ischemia can lead to necrosis there. This is known as renal papillary necrosis, which can easily lead to hematuria in sickle cell anemia. Whereas in aplastic anemia, what is the cause of hematuria? Yes, what is the cause? Who can answer that? Anybody?
Sir, in aplastic anemia, also known as pancytopenia, so all type of blood cells are produced in less amount. So in that condition, the platelets will also be low and will lead to hematuria.
Absolutely. He has answered in such a wonderful way. I don't need to say any other thing. Very good. In aplastic anemia, all three cell lines are going down. There is anemia, there is leukopenia, especially the neutropenia, and thrombocytopenia. So because of the decreased platelet count, okay, aplastic anemia can also have hematuria or any other type of bleeding. Very good. Leukemia, the same reason. In leukemia also, there is pancytopenia. Okay, one of the manifestations of leukemia is pancytopenia, especially thrombocytopenia, which is causing hematuria here. So don't forget these very important causes. Now, another type of causes leads to hematuria, renal malformation, like polycystic kidney. In case of children, okay, we used to say autosomal recessive polycystic kidney disease. But in case of adult, we call it autosomal dominant polycystic kidney disease. That is a bit of difference. Autosomal recessive polycystic kidney disease are very severe condition. The child usually die at the age of 2 to 3 years because of severe renal failure. Whereas autosomal dominant polycystic kidney disease usually manifests in 4th or 5th decade of life, means after the age of 40 or around the age of 50, only the disease will manifest, and they usually have hypertension. Another one is a hereditary nephritis. The example is Alport syndrome. In Alport syndrome, okay, there are two things which are going on. One is kidney involvement or glomerulonephritis, and another is sensory neural hearing loss. The same patient is unable to hear properly. This is a sensory neural type of hearing loss. Now let me explain the meaning. Sensory means cochlea. Okay, cochlea is a part of inner ear, remember that may be affected, or the nerve which is going from the cochlea towards the brain, that is known as cochlear nerve. It's a part of vestibulocochlear nerve or 8th cranial nerve that may be affected. So this is known as sensory neural type of hearing loss. And another one is idiopathic hypercalciuria. We really do not know why calcium is excessively excreted in the urine, and that calcium excretion can also result in hematuria, and this hypercalciuria also can lead to formation of renal stone, and that itself can lead to hematuria. Okay, so these are some of the important causes. Let's move on. Now, a bit of clinical discussion, how to approach to the child. What are the questions we need to ask if I want to diagnose what is the cause of hematuria? It starts from the age. Okay, what is the age of the child when the hematuria start? Important one. If the child is very young, okay, we think separately. If the child is in the school going kid, okay, different causes are there. Remember, Wilms tumor present quite early in the life, okay, and PSGN is more common after the age of 5. So these are the important points. So age is always asked. Another is the duration of hematuria. How long the hematuria lasts? Okay, how long? Is it few days or few weeks? Color of the urine. What type of urine color is there? Now red has got so many different meaning. People perceive it differently. Fresh red colored urine, a bit of Coca-Cola colored urine, a little bit of black tea colored urine, isn't it? Or a very deep colored urine. Okay, or sometimes even black colored urine. Excessively red colored may look like a black colored. So these are the different things. So ask exactly what is the color of urine according to the patient. What is the pattern of hematuria? Is it uniform or is it terminal? Very important question. Uniform means throughout the urinary stream, urine is red. And terminal means, okay, when the patient is about to complete the urination, then only hematuria start. So this is terminal. The uniform type of hematuria is a feature of glomerulonephritis that is coming from the kidney side, or any kidney disease, you remember like that. And terminal type of hematuria is a feature of bladder disease, urinary bladder. Okay, especially when the urinary bladder contracts, okay, then hematuria may start. Asks about other associated urinary symptom like burning urination or difficulty to urinate. Asks about fever and asks about loin pain. All of these are important feature of pyelonephritis. Pyelonephritis. So what is pyelonephritis? Yes, what is that?
Sir, infection of the kidney.
Exactly. It's absolutely right. Infection of the kidney, or you can say infection of renal parenchyma, is pyelonephritis. So these are the important symptoms of pyelonephritis. This fever is high grade fever there with chills and rigor. There is loin pain. Loin is area where kidneys are located. Okay, lumbar area. There's severe pain and associated urinary symptom like burning urination, painful urination, okay, difficulty to pass urine. All those things are there. Asks about the preceding history of throat or skin infection, just to find out the cause, okay, of this particular hematuria. Now we are mainly focusing on PSGN here. In post-streptococcal glomerulonephritis, prior to 2 to 3 weeks, the child may be having infection of the throat, which is known as sore throat, or pyoderma. It's a type of skin infection. Both of those situations can lead to PSGN. Remember, so this question is important. But only less than 50% of the time you get the positive answer. But we don't worry about that. We need to ask this question all the time. Now, there is one big difference between rheumatic fever and PSGN. Remember, both are caused by the same bacteria, that is group A, beta hemolytic streptococci. So what is the difference between those two conditions according to the causative agent? Anybody? What is the difference? Probably you have studied this somewhere else, even in medicine maybe. Yes. Now, a bit of difficult question probably. So listen here, all of you. The group A beta hemolytic streptococci, which has caused throat infection or sore throat, okay, will only cause rheumatic fever. Rheumatic fever is never caused by skin infection strain or pyoderma strain. Whereas PSGN can be caused by both type of strain, throat strain or pyoderma strain. Remember that. Asks about skin rash, joint pain, or other systemic feature, just to diagnose connective tissue disorder, okay, or Henoch-Schönlein purpura. Connective tissue disorder or Henoch-Schönlein purpura. These are the important questions there. Asks about the intake of any drug. Who knows? This patient is a tubercular patient and the patient was taking rifampicin. Until and unless we ask, we don't know. And we unnecessarily think about so many different things, but actually the cause of red colored urine is rifampicin there. So this type of histories should be asked. Asks about the family history of renal disease or bleeding disorder, which may run in the family. Now, during the examination, we mainly focus on these things. Okay, see there, asks about, examine for edema. Okay, examine for edema. Now, edema is examined especially in the lower limbs, in the ankle area. But one important question I need to ask is, from where this swelling or edema started? In case of kidney disease, they mainly start from the facial area or the face, especially around the eye. This is known as periorbital edema. And later on, the lower limbs are affected. Measure the blood pressure, very, very important one. In any type of kidney disease, blood pressure may be higher. Okay. Don't worry about that hematuria. That small amount of hematuria can never decrease the blood pressure. That is not the point here. Blood pressure is usually elevated because of associated kidney dysfunction. Examine for external urethral meatus for local lesion. Who knows? There may be some, scratching done by the child. There may be small wound there. Okay, there may be a bit of, loss of the skin there, loss of the tissues there, loss of the mucous membrane or mucosa there, and that may be the cause of bleeding. So you need to examine that. Palpate for abdominal mass. Okay, palpate for palpable or enlarged kidney, or palpable or distended urinary bladder. Okay, so this abdominal mass are present in tumor like Wilms tumor, and palpable or enlarged kidney are present in hydronephrosis or even again in tumor. But palpable or distended urinary bladder is very important feature of bladder outlet obstruction, and in case of a child, especially if that is a male child, okay, there is one special condition which is known as posterior urethral valve. Posterior urethral valve, which is present in a prostatic urethra. Now, this posterior urethral valve is a type of tissue which only allow one-way flow of the urine. Okay, only one-way flow. That one-way flow of the urine means the natural pathway of urine flow is blocked. Okay, but when we insert some instrument, okay, from the urethral side and we are entering into the urinary bladder, it doesn't obstruct that. For example, cystoscope, there is no problem in the cystoscope insertion, but if urine is collected in the urinary bladder and that urine is trying to go distally towards the urethra and outside, that is obstructed. This is known as posterior urethral valve. Okay, seen in male babies. And what will be the problem now? Because of this obstruction, first urinary bladder is enlarged, then both ureter are enlarged, and ultimately kidneys are enlarged. So this is known as hydronephrosis. Okay, so 2 hydronephrosis and 1 distended urinary bladder. 3 masses present in the abdomen. This is a very interesting type of cases. Now, other type of examination would be systemic exam. You look for the skin lesion. What type of skin lesions are they? Especially more common in HSP and connective tissue disorder. Okay, examine for fever, take the temperature, examine for anemia, examine for the joints, whether they are tender or they are swollen or not, examine for lymph nodes, palpate for liver and spleen enlargement, and examine for the heart. Remember, cardiovascular system is usually affected secondarily to the kidney involvement because blood pressure is increased, blood volume is increased, and that can damage the heart. Don't forget to take height and weight in a child. That is known as anthropometric measurement. Who knows, this child may be having chronic kidney disease, and chronic kidney disease will lead to decrease in height. This is known as stunting. Okay, decrease in height. There are multiple reasons behind it. One of the reasons, okay, is there is a disorder in calcium metabolism in case of chronic renal failure. Now, let's move on. What are the investigation we like to do in a case of hematuria? Please mute yourself. In a case of hematuria, what are the investigation we do? See here. We start with the urine examination. Always, this is a simple type of test, but it gives a lot of information. Dipstick urine, examination and microscopic urine examination. These are of 2 types. Dipstick gives a rapid screening test, also detects hemoglobin or myoglobin. These days, it is routinely done, in every type of urine sample. dipstick test analysis. Microscopic test, tells us whether there is RBC present in the urine, how much albumin is there, what type of WBCs are there, or is there cast present or not, what type of cast. Casts are of different types. RBC cast, isn't it hyaline cast, granular cast? These are the different names. And what is the morphology of RBC? Are they deformed or are they normal in morphology? All this information is provided by urine examination. So always remember, in any type of kidney disorder, urine test is the first investigation for us. Okay. Now, if you are suspecting urinary tract infection, send that sample for the culture, urine culture. And then if there is any growth in the culture, we do culture and sensitivity test as well, which antibiotics are effective against that particular bacteria. That is told by sensitivity test. Go for blood count, complete blood count, ESR, and blood culture. Now this blood culture and blood count is especially useful in pyelonephritis, because pyelonephritis is a serious type of bacterial infection of the kidney, okay, where there is high chance of bacteremia and septicemia. So blood cultures usually show that microorganism. Along with that, urine culture should be done. Okay, we already talked about that. ESR is usually high in any inflammation and infective situation. So this is a non-specific type of test. Go for serum creatinine and urea analysis. Now, in which conditions serum, blood urea and serum creatinine are elevated? Can you tell me what is that situation?
Sir, when the GFR is low, and in many cases like renal artery stenosis and other cases, when the GFR is low, then the serum creatinine and urea is high.
Azotemia.
Good. Both of the students are giving correct answer. Very nice. Now remember one thing: if kidneys are not functioning well, okay, which is known as renal failure, both acute renal failure or chronic renal failure, there is increase in urea and creatinine level in the blood. In other words, GFR is decreased. When GFR is decreased, these are the waste product. These are the excretory product. So they cannot be excreted out of the kidney when GFR is less. That's why they are present in a high level or amount in the blood. If there is decreased blood flow to the kidney, they cannot be excreted. Okay, this is known as pre-renal failure. When kidneys are, working in a very decreased amount, this is known as intrinsic renal failure. Then also they will be high, and sometime post-renal failure is the condition. Means there is obstruction in the urinary flow. So there is back pressure development, and again, these things are high because of renal failure. There are so many causes for that. Ultrasound abdomen is a routine test in any type of kidney disease. We always do that. We want to show, or we want to see what is the size of the kidney. Is it bilateral enlargement of the kidney or only on one side? Is there any associated stone or not? Is there any tumor or not? Okay, is there any infection component or not? So these are the information which is given by ultrasound. Let's move on. Now, what are the other type of investigation? Those are the simple one. Okay, now according to the situation, according to your differential diagnosis, what you are suspecting, other tests are ordered just to confirm the diagnosis, like urine protein creatinine ratio. This is known as PC ratio, protein creatinine ratio. This is extremely important test for the diagnosis of nephrotic syndrome. Urinary protein creatinine ratio is more than 2 in case of nephrotic syndrome. Okay, so it is routinely done. 24-hour urine protein, it is also done for nephrotic syndrome diagnosis. In case of children, the 24-hour urinary protein should be more than 40 milligram per meter square per hour. Okay, and in case of adult, it should be more than 3.5 gram in 24 hours. Then this is known as nephrotic range proteinuria. 24-hour urinary calcium. Okay, this test is done for idiopathic hypercalciuria. Okay, that is a rare type of condition where calcium is excreted, without any reason in the urine. So we can detect that by doing this type of test. ASO titer and anti-DNase B are the important, antibody. Now, can you tell me which bacteria is diagnosed by this antibody test? Which bacteria?
Group A, Streptococcus.
Streptococcus bacteria.
Absolutely, the same bacteria. Okay, group A, beta hemolytic streptococci or Streptococcus pyogenes. ASO titer is anti-streptolysin O titer. Okay, very important, term. And especially in case of pyoderma strain or skin strain, we can go for anti-DNase B also. Okay. Both of these are antibody against that bacteria. ANA and anti-double-stranded DNA. Now, which test is which disease is diagnosed by this test? Which disease?
SLE.
SLE.
Absolutely correct. SLE. Very good. SLE. ANA is a very sensitive test for SLE, and anti-double-stranded DNA is a specific test for SLE. So if both are positive, without any doubt, this is a case of systemic lupus erythematosus. Complement study like C3 and C4. C3 and C4. These are the complement. This C3 and C4 component of the complement system are decreased, okay, in case of certain type of glomerulonephritis, where type 3 hypersensitivity reaction is going on. Because in type 3 hypersensitivity reaction, there is antigen antibody complex formation and complement is also utilized there. So because of excessive utilization or use of complement, the level of these complement will go down. They're decreased, okay, in case of different type of glomerulonephritis. Intravenous pyelogram or intravenous urogram, IVU or IBP, they are the same term. They are mainly done, okay, in case of obstructive uropathy. If something is obstructing the flow of the urine, either in the renal pelvis or ureter, we can go for intravenous urogram or pyelogram. This test is done by, injecting a radio contrast dye or material into the blood and waiting for some time. When that dye reaches the kidney will filter that, okay, and that dye is excreted, that dye is excreted in the urinary tract. Now, during that time, when we take the X-ray, we can see the passage of that dye. If dye cannot go distally from one particular site, then we know there is some obstruction there. If dye is not excreted at all by the kidney, we know that kidney is not functioning well. This is a case of renal failure. So these two particular, important point is told by intravenous urogram or pyelogram. In surgery, we'll talk about this thing in detail. Micturating cystourethropography is MCUG. Now, this is a special type of test which is done for the diagnosis of a particular condition. Anybody can tell me which condition is diagnosed by MCUG? Yes?
Sir, vasoureteric reflex, sir, in chronic pyelonephritis.
Good. This is known as VUR. VUR. Okay. The full form of this is vesico. V is for vesico. Vesico means urinary bladder. Okay. U is ureteric. Ureter. Okay. Ureteric. Vesico ureteric reflux. Let me bring it here. Vesico ureteric reflux. Now let me elaborate on this. The urine which is collected in the urinary bladder is refluxing up towards the ureter because the junction is not functioning well. This is known as vesico-ureteric reflux. Okay. Now, what happens? What is the problem there? If something is like this, what's the problem? Now, the problem is the urine which is collected in the urinary bladder may be contaminated, means it may be having bacteria. And if that contaminated urine is going up towards the ureter, and if it reaches the kidney, it can lead to pyelonephritis. And if this reflux is not treated in time, that acute pyelonephritis will convert into chronic pyelonephritis, which can damage the kidney, and over a period of time, it can lead to scar formation on the kidney, or it can even lead to chronic renal failure. Now, this is a good type of test which diagnoses vesico-ureteric reflux. Now, let me tell a little bit about this. What we do here, we will give a radio contrast material through the catheter. The catheter is inserted from the urethra and it reaches the urinary bladder. So we'll inject some radio contrast material into the urinary bladder and ask the patient to urinate right there. And during urination or micturition, the X-ray is taken. Now, what happens during urination? The pressure inside the urinary bladder will be higher, and that high pressure will cause reflux of the urine if VUR is present. That's how VUR is diagnosed by MCUG. If VUR is absent, then no dye will go up when the patient is urinating right there. Another test is renal biopsy. Okay, this is the last sort of test of investigation, isn't it? Because it is invasive one. I need to take a small piece of tissue from the kidney. It is not that easy type of test. But if it is necessary, it is necessary, and we have to go for it. Okay, if every other investigations come negative and you are suspecting some renal disease, then you have to go for a kidney biopsy or renal biopsy. Let's move on. Now, one important slide here: how to distinguish whether that hematuria is from upper urinary tract or lower urinary tract. How to know that? Upper urinary tract actually means kidneys and ureter, but in this case, upper tract only means glomerular bleeding. Don't get confused. Glomerular is called upper tract in this case, whereas lower tract is ureter, urinary bladder, and the urethra. But if somebody asks you the general question, what is upper urinary tract? You can include ureter in the upper urinary tract. This is anatomical division actually, but this is a clinical type of discussion. So if you don't want to say upper tract, you simply say glomerular bleeding and non-glomerular bleeding. Okay, that is a better type of description. Now, in glomerular bleeding, the appearance of the urine is, see here, it's a tea-colored, tea-colored or smoky urine, or rusty brown or Coca-Cola colored urine, whatever term you want to use, this is the color here. Whereas in non-glomerular, it is bright red in color. So this is a big difference. Number two, there is presence of RBC cast in glomerular type of hemorrhage, whereas in non-glomerular hemorrhage, there is no RBC cast. Now, why is that? We need to understand it. These casts are formed when RBC is passing through those renal tubules, then only casts are formed. In non-glomerular type of hemorrhage, that cannot happen, so there is no cast formation. Proteinuria is higher in case of glomerular hemorrhage because glomeruli is damaged there, so a lot of protein can leak into the urine. And there is dysmorphic RBC usually present in glomerular hemorrhage because when the RBCs are, filtered from the glomeruli, they may be a bit squeezed. Their surface may be damaged. These are known as dysmorphic type of RBC. Whereas In case of non-glomerular hemorrhage, there may be terminal hematuria, which is a case of urinary bladder involvement, or there may be passage of clot if the bleeding is heavy. Proteinuria is usually less than 2+. It is not as high as glomerular hemorrhage, and normal morphology of RBCs are seen. So these are some of the very, very important differences. Now, the final slide, how to manage the case. Now, this is a bit of generalized question, isn't it? There are so many causes of hematuria. So the proper answer would be, I like to find out the appropriate cause and then treat accordingly. That will be the absolutely desired answer. Now, let's talk a little bit about it. Manage the underlying condition after diagnosis. If it is a case of glomerulonephritis, go for the treatment. If it is a case of urolithiasis or kidney stone or urinary tract stone, mainly surgical type of therapy is done. Systemic diseases like connective tissue disorder, you manage appropriately. Trauma, okay, manage again appropriately. And malignancies, find out the cause, which type of malignancy is that actually, and then go for the treatment. Treat the associated problem of kidney involvement like hypertension, very, very commonly seen in any kidney disease. So give antihypertensive drug if the blood pressure is persistently higher. If urinary tract infection is there, go for the treatment with antibiotic. And acute renal failure is usually treated by dialysis therapy for shorter duration. In idiopathic hypercalciuria, restriction of calcium and use of thiazide diuretics are usually given. Okay, thiazide diuretics are usually given in this type of case, because thiazide diuretic will not allow calcium to be excreted, whereas a loop diuretic will lead to excessive excretion of calcium in the urine. So exactly opposite of the effect there. And IgA nephropathy is treated by corticosteroid. So these are some of the management. There are so many other causes, which is not possible to include. If your teacher still wants some better answer, then the proper answer would be find out the cause, diagnose properly, and go for the management accordingly. So at the end, these are the questions, okay, and we'll discuss it later.